At the BGICC this year in 2021, I talked about sequencing endocrine treatment in metastatic luminal breast cancer, solving the puzzle. I also talked a little bit more about the use of alpelisib in the treatment of metastatic breast cancer. In this talk, I reviewed luminal breast cancer and what we see in terms of intrinsic subtyping in metastatic breast cancer, comparing early stage disease, where we see an increase in the less endocrine responsive subtypes. I also talked about the fact that to date, we really don't have any predictive biomarkers to understand which patients respond to targeted agents, particularly CDK4/6 inhibitors in the metastatic setting. But we do know that hormone receptor positivity is required. I reviewed the studies with CDK4/6 inhibitors, including palbociclib, ribociclib, and abemaciclib in the first and second line setting, and reviewed carefully the overall survival data that exists in MONALISA 7 in the first line setting in pre- and perimenopausal women receiving aromatase inhibitors. I talked about the fact that we don't want to combine ribociclib with tamoxifen due to a risk of prolonging the QT interval, but that it did appear that the combination was effective. In the second line setting, I talked about combinations with fulvestrant in patients who'd received prior non-steroidal aromatase inhibitors. One study in one of the MONALISA studies actually looked at patients in the first early relapsing setting, as well as the second line setting in combination with fulvestrant. That to date is the only data that we have in patients in the first line setting with fulvestrant and treated in combination with CDK4/6 inhibitors. These so-called second, with the exception of MONALISA, line studies are quite fascinating because what we saw in these trials was an improvement in progression-free survival, and in several of the trials, an improvement in overall survival. This data actually taught us a lot about the biology of metastatic hormone receptor positive breast cancer and how treatment can vary in terms of progression-free survival and apparently overall survival based on prior treatment. So what we saw was that in the when we treated patients in the second line setting with either abemaciclib or ribociclib, again, ribociclib included this first line cohort, that we saw a marked improvement in progression-free survival, but also an improvement in overall survival that was statistically significant. In the in the MONALISA 3 trial, you couldn't separate out the first line population because first of all, the numbers were not as great, so there wasn't enough powering to really understand the benefit in overall survival yet. And also survival is much longer, of course, in the first line setting. So like the other trials, they haven't really reached the enough events to understand that difference. But in the overall population, there was an improvement in overall survival as there was in MONARCH 2. In Paloma 3, although there was a numerical difference in overall survival, this didn't meet the pre-specified p-value. This trial used palbociclib. And what we learned from this information, which has been fascinating, is that Paloma 3 was the first trial in the second line setting to start. And therefore, the enrollment eligibility was quite a bit more open. Patients could have received prior chemotherapy, and about a third of the patients did. What we saw was that the progression-free survival on the control arm that received fulvestrant was half that in Paloma 3, about half, compared to MONARCH 2 and MONALISA 3, so 4.6 versus a little over 9 months. The hazard ratios were identical, so the benefit from adding the CDK4/6 inhibitor was the same, but there was this sort of shifting to the left with shorter values. And when we looked at this in more detail, what we found was that receiving prior chemotherapy was important. So patients who had received prior chemotherapy had no benefit in terms of overall survival, although there was a benefit in PFS. But patients who had not received prior chemotherapy had a 10-month difference in overall survival with a hazard ratio similar to the other studies. So we know that the hazard ratios are relatively similar in the first and second line settings, but the toxicities are different. palbociclib and ribociclib cause more bone marrow suppression, which is managed by taking a week off every month and by dose reducing and withholding based on neutropenia, but we don't see an increase in serious infections. Abemaciclib, the primary toxicity is diarrhea. This drug is given continuously. And again, holding the drug and dose reducing as well as modifying diet manages this toxicity in the majority of patients. Ribociclib and abemaciclib have been associated with a slight increase in liver enzymes, again, which can generally be managed quite easily. And ribociclib, you have to be careful about the baseline EKG, as you can see a prolongation in QTc in patients who are taking agents that also prolong the QT interval. Abemaciclib has been associated with a slight increase in venous thromboembolic disease, which is also quite interesting and may be enhanced in specific situations, as well as a numeric increase in creatinine, which appears to simply be due to a difference in the testing when abemaciclib is present. There's a lot of studies that are looking at other ways to use CDK4/6 inhibitors, including in HER2-positive breast cancer. And then there are studies, randomized studies, looking at continuing CDK4/6 inhibitors after progression, changing the agent to see whether or not we can maintain efficacy. And I think these are quite interesting studies where we've seen anecdotally some evidence of efficacy when we change the CDK4/6 inhibitor. I then talked about the patients who have PIK3CA mutations, which is the most commonly mutated gene in breast cancer, occurring in about 40% of hormone receptor positive HER2 negative breast cancers. We talked about the improvement in progression-free survival with alpelisib, the only approved agent that targets the PI3 kinase pathway and is an alpha-specific inhibitor. We did see an improvement in progression-free survival, whether the mutation was detected in blood or in tumor tissue, which is also helpful because it gives us another way of trying to look for this mutation. And then data was presented at ESMO and is published in the Annals of Oncology looking at overall survival. Although median overall survival was prolonged by 7.9 months, this didn't meet the p-value required for the study. So we looked actually at subsets as well. And what we saw that overall survival appeared to be even more prolonged in the subset of patients who had lung and liver metastases, although again, this is a secondary analysis, but quite encouraging. The overall analysis didn't meet the pre-specified p-value for overall survival. We talked about the toxicity and managing toxicity in patients who are receiving alpelisib. The major toxicities in the first 2 weeks are rash and hyperglycemia. It's very important to measure the hemoglobin A1C and a fasting glucose before starting and manage glucose ahead of time. And then diarrhea is a late phenomenon that occurs over time. It does appear that maintaining the dose, or at least close to the primary dose, and with alpelisib improves the efficacy, which is very helpful. And then I talked about the recent data from the first 2 cohorts of the BILIEVE trial, a non-randomized phase 2 open-label trial in patients with known PIK3CA mutations, where we looked specifically at patients who'd progressed on a prior CDK4/6 inhibitor, and saw that this does appear to be the agent maintained its efficacy in this setting, which is quite encouraging. In this data, we saw that the endpoint, which was the number of patients who were progression-free, 50% of the patients were progression-free, was, I think, met our endpoint in terms of statistical boundaries. And the toxicity actually, interestingly, improved over time. The second cohort of patients, which we presented at San Antonio, is quite interesting because these patients had progressed on fulvestrant and a CDK4/6 inhibitor. And in those patients, almost 90% of them had disease resistant to an aromatase inhibitor, but we still saw a median progression-free survival that was quite reasonable in patients who received letrozole as the partner with alpelisib, suggesting that alpelisib still maintains activity even in patients who've had resistance to the prior endocrine partner. So this was quite encouraging. And I won't go into those data in great detail, but we talked about sequencing endocrine therapy and still remembering to use everolimus in patients who don't have PIK3CA mutations in combination with exemestane or fulvestrant, and there is data in combination with tamoxifen as well. The ongoing studies with AKT inhibitors, capivasertib and ipatasertib, as well as numbers of studies that are looking at oral SERDs, and then a new class of agents called SERCA, selective estrogen receptor covalent antagonists, that appear to be quite active and maintain activity in patients with ESR1 mutations. And we talked about some studies that are looking at combining immunotherapy with CDK4/6 inhibitors as well. The sequencing certainly has changed. We have a changing paradigm for the treatment of hormone receptor positive breast cancer, now with a number of different targeted agents. And I was happy to be able to share this exciting data with new updates from our recent meetings at the BGICC.